I'm going to introduce Jessica Manson, who is Senior Lecturer and Rheumatologist at UCL, London. And Jessica is going to be talking about the cytokine storm. Probably about a year ago, or just over a year ago, Jessica did a wonderful talk at the Royal College of Physicians about the very subject, cytokine storm. Little did she realise that, a year and a bit later, we'd be applying the cytokine storm to not just rheumatology, but to COVID, which has quite surprised me. So I think, giving the sort of background, there seem to be several stages for COVID itself. So there's the actual attack by the virus, and Jess can correct me. And then there's a kind of second stage where people feel like they're getting well, but then they spike a fever and start an autoimmune or autoinflammatory process where they start to destroy their own tissues. So I'll let Jess talk now about the cytokine storm. Thanks, Jess.
Oh, thanks. Thanks, Stephanie. Thank you very much for inviting me to give this webinar. So yeah, it's really tricky. I think we know very little about COVID-19 in spite of the large number of cases, just because of the short amount of time that it's been around. But it certainly seems as though there's an initial insult, which is direct viral damage to the host. And then, as you say, some people seem to have this reprieve, get better. And then there's a second hit. For some people, there's a continuous illness, and for some people, there's a second hit. And certainly during the second hit, often people have extremely high fevers and very high CRPs, and sometimes, but less commonly, high ferritins. And there are features of that which resemble cytokine storm syndromes like HLH. HLH is really how I got into this game. But what's not completely clear is whether by that point the virus has been cleared by the host or not. So we still don't entirely know that, whether it's now just the host's immune system overacting in an overzealous way, or whether there's actually still virus hiding perhaps in the lung. And that makes this decision about treatment even more complicated, because clearly you don't want to completely switch off the immune system if in actual fact you still have active viral damage as well.
Yeah, thank you. So a good question that came up before was that people who are already on anti-TNFs, let's say for psoriatic arthritis, RA, are they more protected in some way from the cytokine? We probably don't know this, but are they more protected from the cytokine storm, or are they much more likely to get COVID?
Oh,
This is something we just don't know.
Isn't it? I don't think we know the answer yet. There's a very nice European study, which my colleague Sue-Ann Yeo at UCLH is collating our data, but where we're all trying to answer that question. So number one, instinctively, one would think that if a patient were immune suppressed in the way that many of our patients as rheumatologists are, that they would be at increased risk of infection because they are for other infections, therefore at increased risk of infection with coronavirus. But then you have to wonder whether, if actually some of the damage is coming from this overzealous hyperinflammatory state, whether in fact the drugs are protecting them. And we just don't know the answer to that question yet.
Mm. So would you say, I mean, you've worked on the front line as well, haven't you? You've been on the front.
Yeah.
So are people kind of waiting, the first week and then saying, oh, actually, should we recheck the CRP? Should we look at temperatures? And then looking for those vital signs of autoinflammatory response, and then saying, well, we better intervene, or has it not got that far yet?
So I think there's definitely an awareness. Tocilizumab, for us rheumatologists, tocilizumab has been a word that we've all used freely for many a year, but suddenly, non-rheumatologists, non-medics are using the word tocilizumab because of the trials in China and in Italy and then in France. So there's certainly a much bigger awareness of the drugs and the potential for intervention, and of the concept that blocking a cytokine or modulating the immune system might be helpful. So I think what's happening is that patients are sometimes presenting fairly late, and then they're presenting with signs of a very active immune system. Whether that's, as we say, completely appropriate or completely inappropriate, or a bit of both, isn't clear. Clinicians are actively looking at these patterns and trying to understand when best to intervene. But at the moment in the UK, and I've come to think very sensibly, all cytokine modulation should be, I think, within the remit of randomized controlled trials. And there are now trials available, multi-center, including recovery, which we can talk about in a bit. And so I think that at the moment, clinicians shouldn't be reaching for drugs until we have data that they do more good than harm.
Okay. Do you want to show us a picture of the cytokine storm?
Yeah, should we go back to the sort of beginning of the story a bit? Let me just, so the reason that I as a rheumatologist am involved in this, so I hope that you can see my screen now, can you?
Yes.
Okay.
Lovely.
So this rather beautiful figure, designed by my colleague Chris Bauchmüller, who's an intensivist in Sheffield, and is accessible through this paper that I reference here in the Journal of Intensive Care Society. So Chris and I are members of a UK cross-specialty group called HASC, the HLH, a cross-specialty collaboration. And I set this up 2 or 3 years ago with my colleague Rachel Tattersall, who's an adolescent rheumatologist in Sheffield, really with a view to improving the outcome for patients with hemophagocytic lymphohistiocytosis, or HLH. And really, HLH is the prototype cytokine storm hyperinflammatory state. So this is a really lovely picture showing how HLH comes about. So if we've time, Stephanie, perhaps I'll just take you through it a wee bit. So we think that some people are more at risk than others. And so there are a whole cohort of patients, often children, but not just children, who have what's called primary HLH, where they have a genetic problem and they develop recurrent hemophagocytic lymphohistiocytosis, to the extent that if they don't have a bone marrow transplant, they're very likely to die. And most of these people present in childhood, although there's a famous case of a man, I think in his 70s, from Swansea, who presented who had actually a genetic primary HLH. But most of the HLH that I am involved in is secondary HLH. And there are 3 main drivers. The first is, and why I'm involved, are rheumatological diseases. So in our hands, that would be adult onset Still's disease and lupus, and in children, systemic JIA. The second are cancers, and the most common are hematological cancers like lymphoma and leukemia. And then the third, and probably in our bit of the world, the biggest driver for HLH are viral infections. So this is where COVID coronavirus comes in. So as you see, what happens is you have an infected, in this case, infected cell. And whereas what would normally happen is that after a while, the whole process of inflammation will be switched off because you've either cleared the infected cell or had your cancer treated. But in this case, what happens is an inappropriate, endless positive loop of inflammation, such that you have these very activated macrophages that you can see here. And then the macrophages do a number of things. One of the things they do is they eat other contents of the bone marrow and of liver and elsewhere. So that's where hemophagocytosis, so eating of blood cells. And then they also produce and lead to production of other cells too, of massive amounts of cytokines. And you'll see them listed here. So key to our discussion this morning, perhaps, is the release of IL-6, you'll see, which is what tocilizumab blocks, but also IL-1, which is what anakinra blocks. And then you mentioned TNF-alpha, and you can see that there too. And then it's the cytokines which go on to cause this systemic inflammatory response. So patients with full-blown HLH have multi-organ damage with fever and very high ferritin and high CRP. And it really is one of those, a true multi-organ dysfunction where, you know, over time everything fails and all these patients are on intensive care if their process is not switched off. So what we saw in COVID, what we see in COVID is that there are a few patients who present really with very classical HLH. So in other words, this combination of fever, very high ferritin, cytopenias, liver dysfunction, and respiratory involvement. But actually many of the patients are presenting with a slightly different syndrome, which is not so familiar to me. which is a very, very lung dominant syndrome. So we all know that these patients are requiring NIV or intubation. Although we heard over the weekend quite a lot about the problems related to kidney dysfunction, it often at least starts off being a very respiratory dominant syndrome. And so there does seem to be perhaps more than one subtype of hyperinflamed COVID. So there's the small percentage who have HLH, and then there's a bigger group who have a hyperinflamed lung syndrome. So they have a very lung dominant syndrome. They need respiratory support and high oxygen, and they have super high CRPs and moderately elevated ferritins.
Mm. That's brilliant. Would you say then the most important, would you say IL-6 is the most important player, or can you not really say at the moment?
I mean, we don't know. I mean, the fact that the CRP is so high, sometimes 300-400, would certainly point to IL-6 being important, because IL-6 drives CRP, as you know. Mm-hmm. But yeah, we don't know the answer to that question. And the other thing is that the data we have about, you'll have read papers where people have been measuring serum cytokines. So from the Chinese data early on, there was information about high serum IL-6, and perhaps a suggestion that high serum IL-6 might predict better outcome if you then use IL-6 inhibition. But I think one of the big questions is whether really measuring serum cytokines gives us a proper feeling of what's going on with these patients. Because as I've said, it can be such a lung dominant syndrome that unless we were able to sample from the lung, which is not possible usually because these patients are too ill, we don't really know what's going on in that microenvironment. There's some very exciting data coming from postmortems, not very cheerful, but very powerful, you know, and I think that may help us understand more. Suggesting that not only is there a lot of inflammatory change, but there also might be microthrombi contributing to the pathology too.
Yeah, so this is a very interesting thing. So intensivists have said that everything clots, clots like mad, and they don't know why. Do you think that is part of the cytokine storm, or is it a separate phenomenon?
I mean, we often have a combination of clotting and bleeding in HLH and in cytokine storm. But again, I don't think we know at the moment, but I'm sure that both need investigation and thoughtful therapeutic approach.
Yeah. We've had another question. So to what extent are cytokine storms an autoimmune response, or I guess an autoinflammatory response?
Okay. Yeah, good question. So in my mind, they fall into the more autoinflammatory category, in that you don't usually identify antibodies. So for the non-rheumatologists, we typically talk about autoimmune illnesses being things like rheumatoid arthritis, where you'll have an anti-CCP or a rheumatoid factor, or lupus, where you'll have an ANA and an anti-DNA antibody. Whereas I think by contrast, adult onset Still's disease, we would consider more of an autoinflammatory condition where you don't identify specific autoantibodies. So I think we don't know, but this more resembles an autoinflammatory condition.
Yeah, so more like adult Still's, or
that sort of thing.
And in terms of the clotting side of things, have people measured antiphospholipid antibodies, anticardiolipin?
Good question. I don't know the answer to that. There's certainly lots. Yeah, that's a really good session. So Marcel Levy, who has about 16 jobs, but he's the chief exec of our hospital. He's also an acute physician. He's also a clotting expert. I know he's done a webinar on the coagulopathy. Yes. So certainly there are super high D dimers in some of these patients. And as you say, evidence of clotting. And people are looking at plasma exchange and other things that are used in clotting syndromes too. But yeah, good question about antiphospholipid antibodies, and not my area of expertise, I'm afraid.
And then there were a few questions before the webinar was started about Kawasaki type presentations. I know that you're an adult rheumatologist, and we talked about that, whether we should have a session on, adolescent or pediatric rheumatology.
Yeah, I think you probably should. I think there's great anxiety amongst pediatricians, pediatric rheumatologists. So we've been having the HASC group I mentioned, this UK-based hyperinflammation HLH expert group. has about 188 members, and we cover all age groups, including so paediatricians and adult specialists. And on the call last week, there was quite a lot of discussion about Kawasaki and whether COVID caused a sort of atypical Kawasaki. So I am not a paediatrician, as you say, this is definitely not my expert area, but what I understand is that they're seeing more children. This is apparently Kawasaki season, so this is the time where they see Kawasaki, but they're seeing more than they would expect. And it's also not completely typical Kawasaki. From what I understand, some of the children have not tested positive for COVID, but I know from my adult practice that we saw patients where I would swear blind they had COVID, but on multiple swabs they've been negative. And the other thing is that actually the process of swabbing a child is difficult. It's not nice for anybody, but you can imagine technically more difficult on a child, although there is some merit in doing rectal swabs as well as oral swabs and looking in stool for COVID, which we also sometimes do in adults too. So I think the jury is out, but I'm certainly getting lots of emails from paediatricians asking questions about that. I haven't seen reports of coronary artery aneurysms in adult COVID, but I may have missed them.
And the other thing is that the treatment obviously is very different from what we're talking about. So for Kawasaki, I imagine it's
IG, I understand, and steroids, but again, I'm not
and aspirin they're using,
and aspirin,
yeah, but they're not using anti-IL-6 and so it might be.
Well, I mean, if they were, they'd be doing it outside of trials. And as I've said, I think for the minute, given how little we know, we probably want to be doing things.
Okay. And there's a question about Spanish flu here. Why do you think that, so Spanish flu apparently triggered many cytokine storms, and that was suggested as a reason why most deaths were seen in the under 65s. If COVID-19 also causes cytokine storms, why don't we see the same distribution of deaths?
Yeah, so I think they're not all dying of one thing, is the truth. So I think that there are a proportion of patients who have multiple morbidities and frailty, and COVID-19 causes them to die because they are at increased risk and frail to start with. And we've seen links with diabetes and obesity, and there's very frightening data over the weekend about link with poverty as well. And that's probably a different risk than the death, or overlapping perhaps with the death from hyperinflammation. And without I don't want to not answer your question, but I don't think we have the answer for that yet. I mean, certainly in our unit, right from the very start, we had some people not many, I agree, but some people in their 20s, 30s, 40s who had very severe COVID, who wouldn't fit the phenotype. But it's still very clear that the epidemiology shows that it's the over 80s who are at highest risk of dying.
With a cytokine storm, or?
Well, I don't know. I don't think we know that yet.
We don't know yet.
We're trying to define that. I mean, just to go back one step, how do you define a cytokine storm? What does that exactly mean? And we're trying to, by looking at data, trying to make some definitions, because ideally the randomized control trial you want to do is to only give immunomodulatory drugs to patients where the cytokine storm is a problem, rather than to patients who have multi-morbid vulnerability, and suppressing their immune system could make them worse rather than better.
Exactly. Oh, very difficult conundrum, isn't it?
And we feel that, don't we, as rheumatologists? I think it's really interesting having non-rheumatologists suddenly keen to use our drugs, but I think we come at it with anxiety about the dangers of these drugs, as well as the incredible benefit. I mean, we all know how biologics have completely transformed the life of so many of our patients, but not without risk.
Quite. So any more about the lung side of things? So why do you think COVID particularly picks out the lung?
Presumably it sits there. So, I think that is why. And although we do see other systems involved, and as I said over the weekend, there was a lot of discussion about the amount of renal replacement therapy that was needed, to the extent that in the UK there was concerns about running out of fluids. Yeah, presumably it's because that's where it goes and it sits and it's not cleared, and it's taken up preferentially perhaps by those cells. But again, we don't know the answer to that question.
Okay, so someone else is saying, is it a pulmonary vasculitis? Have we any evidence for that?
So I guess we would own, is it a pulmonary vasculitis? I don't think we have evidence for that. I don't know. It would be interesting to know what comes out of the post-mortem trial. So I think it was at Imperial where they're doing some post-mortems, which is obviously requires a particular level of protection for staff and needs to be done in a very safe environment, but we will learn a huge amount from that. And, you know, we should be very grateful to the families who've allowed the bodies to be used for research in that way.
So I've just got the comment here that there are reports of positive antiphospholipid antibodies.
Oh, great.
And then another person saying, people with antiphospholipid syndrome, are they more vulnerable to COVID autoimmune complications?
Again, I just don't think we know the answer to that question yet. No, and it's interesting. David Eisenberg was on last week, wasn't he? And he has a good handle on all things antiphospholipid and didn't mention it, which probably means that in that world they certainly haven't got those data yet. But it comes back to collecting data. We all have a responsibility, I think, to collect as much data as we can and share everything we can.
Yeah, and do you want to talk a little bit about the trials that are ongoing now?
Shall I just show you? I've done an interesting 180 on this during COVID, so I'll talk you through this slide in a moment. But when we first started seeing patients, I shared, I'm sure with others, the absolute feeling of helplessness of seeing young, in my case young, because I was looking at a particular cohort, very sick people desperately wanting to do something. I think there's two, anyway, so to begin with, I rather supported the idea of what's called compassionate access to drugs, which is where you just have a go. But I've really actually done a 180 on this, and I've now completely accepted the concept that we should only be using immunomodulatory drugs within trials. So there's an exception to that, and I'll come onto this slide in one moment. So if you have a patient who has full-blown hemophagocytic lymphohistiocytosis or HLH, then you should treat them like you would if there were any other driver. So a year or so ago, I saw a young girl with EBV-induced HLH, and you should treat COVID-induced HLH much as you would if you suddenly saw a 19, 20-year-old with EBV-induced.
That's very clear.
Because otherwise you're under-treating patients, and that's not right.
Okay.
So that is because that is standard of care. That is different to using tocilizumab or anakinra or ruxolitinib in a patient who has a syndrome that is really a COVID-induced hyperinflammation that doesn't meet the criteria for something that we recognized before. And I now feel, as I said, very strongly that we should only be treating these patients in the context of randomized controlled trials. So listed here are the observational trials, ISRIC, which many patients around the UK have been involved in and has begun to report some data, which is very useful. And then 3 interventional trials. And this document has been produced by CTAG, which stands for the COVID-19 Therapeutics Advice and Support Group. This is run by Andrew Barron and Richa Sofat, who are pharmacy/clinical pharmacologists in North Central London, and loads of people have gone in to help. And that website is useful, and this document is continually updated and has become out of date, I hate to tell you, over the weekend, but there we are. So recovery, as many people will know, is a randomized controlled trial for hospitalized patients with COVID-19. So there need be no more measurement of severity apart from to say that the patient requires hospitalization. REMAP-CAP is a platform for critical care. So these patients need to be on a critical care unit to be entered into the trial. And those are both CMO supported UK trials. COVACTA is a pharma funded trial Also looking at, so tocilizumab is now in each of these 3 trials, and you'll see that anakinra, which inhibits, excuse me, IL-1, is also in REMAP-CAP. So I think that it's incredibly exciting that the UK is actively recruiting into these trials, and hopefully we'll start to get some data. There was some rumours in the news over the weekend that a French trial of tocilizumab in COVID-19 had some positive data, but I've yet to see the data. And so far, everything that's been reported is not randomized control trial data, it's case series data, which I think is very interesting and useful, but clearly is not yet the answer.
No, and when do you think we'll get some results from recovery? Because it's got the IL-6, the IL-1.
Yeah. So the IL-6 arm of recovery only started last weekend, I think.
Right. Okay.
So I think that will take some time, but you know, everyone gets it, right? They get the pressure. They get that we need to get data out there quickly, and I'm sure that the PIs of recovery and REMAP-CAP are keen to get data published as quickly as they can. Remember though, we are behind others internationally, and we, with any luck, will get, I know of a good trial in Italy and in France, and I'm sure there may well be more data to come from China. So we must learn from others too. And given they had the infection before us, they may well have data before us too.
Oh, that would be interesting and good. Now there's a couple of questions. One about vitamin D. So there's a vitamin D story, and also about steroids. Are we going to lower steroids or up the steroids? What's the
using steroids to treat COVID, or?
Yeah, when?
So I think steroids are jolly tricky, aren't they? So for patients who are on, our patients, rheumatology patients or other patients with chronic diseases who are on steroids, then again, we mustn't forget the medicine we knew before. So if a patient is unwell with a fever and they're on steroids, then they should know to increase their steroids to cope with the infection, and that rule continues. And I think Sarah Mackey from Leeds and others, Pooja Mehta, is doing some work on this to try and ensure that patients still follow the advice they've had previously.
Yeah.
That's not quite the same as treating COVID with steroids. And we know that there is great anxiety about the fact that steroids may make things worse at some stages of the illness. And there's controversy about the role of steroids in ARDS. And we know that some patients with COVID get ARDS, but there's enough uncertainty to support there being a dexamethasone, a steroid arm to the recovery trial. So, you know, steroids remain thorny, and I think the jury's out. But certainly, again, if a patient had full-blown HLH, I would be happy to use steroids in the way that we have historically. And it's important that our patients don't abruptly stop their steroids, because then they'll become Addisonian and have another problem.
Absolutely. And what about the vitamin D story? So there's a circulating. I don't know it myself.
I don't know about vitamin D.
Oh, okay. Yeah, I think David knew, and I forgot to ask him. But
oh, bother, David knows everything. We'll have to ask him. I don't know the answer.
No, okay. And
I think probably all of us who are not getting much sunshine ought to have some vitamin D supplements.
We should, shouldn't we?
Just generally. But I don't know about it in COVID.
There's another question about hydroxychloroquine. Do we know the answer to this? Are they patients on it already? Are they more or less susceptible to?
Yeah, again, we don't know. I mean, what is important is that we have an evidence-based use for hydroxychloroquine in, for instance, our lupus patients and our inflammatory arthritis patients. And I think we need to actively protect their access to drug, and again, we should only be doing things when there is good evidence to do them in COVID or in a context of a trial.
Yeah. Somebody else asked about Graves' disease, so general autoimmunity. Do you think people are more likely to get a cytokine storm, or do we not know?
I don't know. It's really difficult, isn't it? So I think that, so I don't know much about Graves' disease, I'm sorry. But I think in patients who have, for instance, Still's disease or systemic JIA, if we just go back again to the medicine that we do know, then it's often a viral trigger that will push them into having a cytokine storm that is HLH. So presumably, if you have a genetic risk to get sorry, it's my phone. If you have a genetic risk to get a cytokine storm as a result of a viral illness, then I would assume that that's true of COVID as it is of other things.
So back to a kind of genetics flavor, what about ethnic minorities, or I was also thinking about HLA-B. There is an HLA-B predisposition, I think. There has been a paper on that. Anything that you know about that, or why the...
So I don't know. So we're trying to define with a research group with Newcastle, Nottingham, Sheffield and UCL. We're trying to define what COVID-related hyperinflammation is, and we are gathering data on ethnicity, but I don't have any data on that to report yet.
No. We've had a huge number of deaths, or it seems like a huge number of deaths from the ethnic population, and I'm just wondering how many. We don't know how many of those were cytokine storms, or
we don't.
Virus.
Yeah. So one of the big problems, it comes back again to this problem that we don't yet have a strict definition for what the cytokine storms that we can see in COVID-19 are. Yeah. We also don't have a good handle on the total number of people who've had COVID-19. So percentages are really difficult to come by.
Okay, and I think you already touched on this, but Simon Allard's asking, what's the evidence for any detectable residual viral antigen in patients with the cytokine-induced storm, with the COVID-induced storm?
So I think there is some evidence of that from the post-mortem data. And that's one of the reasons why I think we need to proceed with caution. Because we must do no harm first, right? So I think that the randomized controlled trials are the way to go, and we have to wait for those data to come out before we make anything that modulates the immune system standard of care.
Yeah, very good. Anything that you would like to add yourself, where you think your research is going to go in this field, or in rheumatology itself, strictly or unrelated to COVID, and we can kind of wrap up after that?
Yeah, well, I think it's COVID's been an awful thing to happen to the world, but people have responded amazingly, haven't they? I've seen, we've had a ward at UCLH that we as rheumatologists have been helping to run, which is a pediatric ward staffed by pediatric nurses. Part of the people on our rota running a COVID ward were pediatric doctors. So it's brought people together fantastically. And I think that working in hyperinflammation brings people together also from multiple specialties. And I'm hoping that we'll get some proper good trial data out of this pandemic, so that we can save lives going forward, and also that the collaborations we've had that have been sort of forced together quickly during a pandemic will continue, because we just, as specialists, don't we learn so much from working with people who have other specialist interests. And so my dream in HLH, in a way, it has always been to have randomized control trial of managing super sick patients with cytokine storms. And not that I ever wished a pandemic on anybody, but we may actually get some data on how to treat these patients. So that would be one positive thing. Yeah,
very much so. And we're going to have Chris Denton, who's going to talk about the lung,
COVID,
the fibrosis, and what's the driver for that, because we have disease parallels with scleroderma, very severe. Scleroderma. So that's happening on the 20th. And
that'd be great.
Yeah, and we need to find a pediatric person.
Okay, I can recommend some.
Probably. So if we can get our heads together about that, that'd be great.
Yeah, definitely.
But thank you so much for really enlightening us. It's been fantastic, so helpful.
Thank you. Thank you for having me.
Yeah, all the very best. Thanks.
See you soon. Bye,
Bye.
Stephanie.
Bye.
Thanks.